Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. David, who do we have as our next guest at Health 2021?
Well, John, we are fortunate to be here, and of the 6,000 people that are around, we landed Alicia Stokes. She is VP Strategy, Planning, and Performance for Government Markets at Blue Cross Blue Shield of North Carolina. That's who we have.
Welcome, Alicia. Tell us a little bit about your role and about the Blues in North Carolina. You're kind of a relevant plan in that state.
Yeah, somewhat. First of all, thank you all for having me. I've been at Blue Cross North Carolina for about 8 years now. I started off in our healthcare division, working on a lot of the value-based payments and helping formulate how Blue Cross North Carolina formed a different relationship with providers. So really working a lot on the ACOs and kind of moved to value front. I was there for about 3 or 4 years and then transitioned over to our enterprise strategy area where I managed our competitive and market intelligence team as well as our innovation arm of the company, and had a brief stint leading our consumer intelligence and our insights team and also our consumer experience team. And then about 7-8 months ago, I had an opportunity to switch over and have more P&L ownership and association. And now my role as the Vice President of Strategy, Planning, and Performance in Government Markets, my role is really to ensure that the long-term strategy for our Medicare, Medicaid, and our federal employee plan business is sustainable and can help us reach our membership and revenue and growth goals. I have accountability for our long-term go-to-market strategy, our marketing strategy, our product ideation, and any sort of large-scale strategic partnerships that we need to endeavor on to help us further our goals.
So, Alicia, tell us a little bit about Blue Cross Blue Shield of North Carolina, because in the state of North Carolina, you are the reference plan, and you are the brand that people think about when they think about health insurance. What kind of responsibility do you think that puts on the plan, and what kind of position does that put you in government programs, which has not historically been Medicare, Medicaid, where Blues plans have really distinguished themselves, and yet Blue Cross Blue Shield of North Carolina has leaned in hard.
Yeah, absolutely. So number one, we at Blue Cross North Carolina, we are all about serving. Our purpose statement is to improve the health and well-being of our customers and our communities, and we will not stop until healthcare is better for all. We have been largely focused in the commercial space, so think ACA, think employer groups, underwritten groups, things of that nature. But I think some of the movement that we've seen in the federal space is that folks are really, really jazzed and excited about the Medicare Medicaid space. In July of this past year, we went live with Medicaid transformation in North Carolina, and so we've really, really leaned into that via our partnership in forming Healthy Blue. And so I think when we think about what our opportunity is and where we can really help contribute to the health and well-being of our customers and communities in North Carolina, we really see that we should be serving all North Carolinians. I think we've seen some real movement in some of the distinct programs that we have within the plan. So think about Blue Premier, which is some call one of the fastest move to value programs in the country. At only 2 years old, we've generated approximately $350 million in savings while delivering quality improvements and health outcomes improvements. We've seen some real movement in our STAR scores. So this year for 2022, both our HMO and PPO plans for MA are ranked at 4.5 stars. And then just going back to Blue Premier, overall, as far as health outcomes are concerned, we've seen some great improvements there. Roughly, adults with Blue Premier providers saw approximately a 15% reduction in unplanned hospital readmissions. And so I think how we think about our plan is North Carolina is our backyard. North Carolina is our home turf. We are local. We are the longest standing insurer in the state at 88 years strong. Our CEO, Dr. Tunde Satunde, has a local presence. He answers the phone when our communities call. He spends time in our communities from the mountains to the coast. And one of the things that I love best about our plan is that we are not beholden to shareholders. We have a mandate to improve the health and well-being of our customers and our communities, full stop. And we make sure that everything that we do is in the spirit of supporting and enabling our customers and our communities.
Alicia, Medicare and Medicaid are programs that have been around for a while. They started in the 1960s, which was some time ago, and of course they're not.
You remember that, David? You were around. I mean, what was
John,
it like?
David was 4. when that happens.
There we go. Thank
spring
you.
chicken.
Thanks for a little. We're going to have you on the podcast more often here. Yeah, I was just getting around. As you know, Lyndon Johnson didn't call on me directly. It wasn't LBJ.
He could have.
There were a lot of LBJs in the family, Lady Bird, etc. But I didn't. I wasn't one of those. But maybe next time he will. They did talk about the Boston to Austin axis, however. So maybe he would. In any case, thank you. So there's been changes since those times, but are there continued opportunities that you see to modernize Medicare and Medicaid, and are you optimistic about whether we'll be seeing progress in those areas?
So let's hit the second one first, and then we'll go through some examples that'll answer the first question. Number one, yes, I'm very optimistic. We see payers all across the country really investing in opportunities to modernize both Medicare and Medicaid. We're seeing a lot of traction in these efforts. I think with respect to Blue Cross North Carolina, there's a couple things that we know. Number one, we know that health goes beyond the physical care in the doctor's office, and we must get better at integrating physical and behavioral health and really addressing those non-medical drivers of health. We must also get better at investing in our community, investing in community health partnerships with our community organizations. I think one of the things that really excites me about Blue Cross North Carolina is while we look to improve the health and well-being of our customers and our communities, we really look at what organizations currently sit within the community and making sure that as we really look to improve the health and well-being for our customers and our communities, that we are not alienating those organizations that currently exist. In North Carolina, as I mentioned before, we're in
Has that happened before? Has that been a real issue for some of the Blues plans?
I can't speak to whether it's been an issue to some of the Blues plans, but what I can tell you is that we are being incredibly intentional about it. Under the new leadership of Dr. Satunde, as well as the leadership of Dr. John Lumpkin and our Drivers of Health team, which I'll talk about a little bit later, we really are focused on making sure that not only do we meet the community where they're at, but that we understand the current infrastructures and the current organizations that sit within the community and how we can better partner with them to support where we're all trying to get as organizations that really look to help influence the healthcare ecosystem. So that's one of the things I'm really, really excited about, is being able to leverage these community partnerships in order to help further our purpose and help further those organizations' purpose as well.
Drug pricing is a major issue these days just because the price is so high and it is consuming so much of the healthcare dollar. And I know that that Blue Cross of North Carolina has a partnership with the EQRX. And I mean, how do these things fit together? Are you really tackling it head on?
Yeah, so first I think it's helpful to just start off with some statistics that can kind of lay the groundwork to emphasize the importance of being able to impact drug pricing. Since 2014, prescription drug prices have increased by 33%, and that's far outpacing the other medical services that are really driving healthcare costs. We know at Blue Cross North Carolina that 50% of the increase in our members' healthcare spending is from rising drug costs. And we know that specialty drugs are part of the problem as well. They account for roughly 1% of overall prescriptions, but they really drive half of that pharmacy spending. And we also know that this has a disproportionate impact on Medicare and Medicaid patients. So now let's talk about kind of what we're doing globally as insurers, and then we can talk more specifically about what Blue Cross North Carolina is doing as well. Number one, we as payers must work to increase competition in this space among pharma manufacturers. We must promote generics that ensure that Medicare and other drug purchasers can negotiate lower prices, especially where high-priced drugs face little or no competition. We must increase transparency, not only in price, but also in effectiveness for our consumers and providers. And one point I want to emphasize here is we must increase that transparency in a way that consumers and providers can understand and utilize. And then lastly, I think, us as insurers, we must support reforms that promote and speed competition from generic drugs and biosimilars. We have to stop these patent abuses that delay generics and biosimilars from coming to market.
So as you think about that long list of necessary reforms,
yeah,
how do you as an insurer kind of punch back at pharma's grab of what's effectively 1 out of 4 consumers who are on chronic medicine can't afford all of their prescriptions? I mean, they even with coverage.
Yep.
This is not people who are not covered. Is EQRX sort of an aspect? Can you just talk a little bit about that? Or?
Yeah, I can talk a little bit about EQRX. So EQRX is really focused. So let me back up. EQRX is a biotech startup, and they're focused on lowering direct member costs and creating new specialty medicines at radically lower prices. We feel like that they will specifically target specialty drugs, so think oncology drugs. We all know that those are notoriously expensive, and we're thinking that this partnership will deliver tremendous savings for our members. However, there are other things that we can do working more closely with our providers. So for example, Blue Cross North Carolina pharmacists, so pharmacists that we have in-house, are assigned to our Blue Premier partners to support members with chronic conditions who are eligible for medication review and condition-specific health screenings. And then we also have an RX Savings Solutions program, which looks to scan drug options and different savings opportunities for members and really help them maximize our prescription benefits. But again, one of the things that I really want to highlight is that transparency portion for both consumers and providers is critically important. It has to be at the point of care, it has to be at the point of decision making, and it has to be delivering insights and information to consumers and providers that they can actually grasp and leverage in order to help give them the best price and the best effectiveness within their medications.
So if I think about my 88-year-old mom as a cancer survivor, she's got a bunch of chronic meds. What if you have the system that you want? How would she experience transparency in a world that you could design that was more transparent around drug prices and options?
Yeah, so close your eyes and imagine a world where she or her caretaker shows up at Walgreens to pick up her medication, and the pharmacist says, "Did you know that you're supposed to be on this medication, but actually there's another medication that has the same amount of effectiveness that's going to cost you $200 less?" Right? And at the point of care, she can get that medication, right? And she can actually pay a lower price, but still have the right amount of effectiveness, right? And that information is also being transmitted back to the provider, right? Because you can't, a pharmacist is part of the care team, but at the end of the day, like we've talked about before, as you move to value, it's the primary care physician who really has accountability over the patient outcomes. So the transparency not only has to be with the consumer, but then we also have to be able to bring that information back to the provider and make sure that they're in the loop, right? Make sure that they understand that there's an opportunity to switch to a more effective, lower cost medication, and that they're doing the right kind of follow-up and correspondence to really make sure that the health outcomes are trending the way they're supposed to.
So is your goal to be that connective tissue between
That's exactly right.
the different parts of sort of the virtual, we talk about at CareCentric, we talk about care traffic control, but it's also about the flow of that information. You can't influence what you don't know about.
That's exactly right. You can't influence what you don't know about. And this is where, I get a little bit kicked under the table with my constituents at Blue Cross, but we cannot deliver that information late.
No.
Right? Because
it's gotta be real time.
if your mother is going to the pharmacy at 5 o'clock on a Friday afternoon, as most people do, right? If that information is not given to that pharmacist and given to her right then we risk she's splitting pills because she can't afford the actual prescription that she went there for, right? An 88-year-old person, or no one for that matter, should be put in a position where they are forced to split pills all because they can't afford the right pill, the right place, the right time.
It's
so we
insane.
have to do better. Full stop. We have to do better.
Now, what about food security? Historically, that's not something you'd think about that a health plan would need to be involved with, but I know that you've been active there and have some partnerships as well.
Yeah, so I think there's a stat that a lot of people refer to that 20% of health outcomes are linked to medical care, and the remaining 80% stem from this socioeconomic, environmental, kind of non-clinical markers of health, right? Think safe housing, transportation, access to healthy foods. I would argue that Medicare and Medicaid beneficiaries are disproportionately impacted by these non-medical drivers of health, and I think the pandemic has just exacerbated that beyond belief and really serves as a painful reminder that good health doesn't just happen in the provider's office. Simply put, we cannot improve health without addressing these non-medical drivers of health. We focused on prioritizing food security because it is the most commonly reported unmet social need. And so we have a drivers of health team, as I said, led by Dr. John Lumpkin, and they're really testing innovative models to find effective long-term strategies for addressing drivers of health needs. So they're doing things like collaborating with local organizations to provide eligible members with a monthly benefit stipend for fresh food. They have a food delivery and kind of health coaching model for members with type 2 diabetes that are facing food insecurity. But I think one of the biggest bodies of work that the team is really collaborating on is to help increase not only awareness of SNAP, the Supplemental Nutrition Assistance Program benefits, but also to help increase enrollment in SNAP. So we know that lack of awareness and stigma and bureaucracy are all barriers to SNAP access. We also know that on average, throughout the course of a year, an adult with low income who participates in FNS SNAP will incur roughly $1,400 less in medical care costs than an adult with a low income who does not participate. And so one of the things that we're doing within our organization is our social workers have the ability to screen members for our program to see if they're eligible for SNAP. And if they are, they connect them with a third party that can help them through that complicated enrollment process. And then it also makes sure that the members are receiving their full amount of benefits for which they're eligible. We're also doing some things to provide financial support to our local food banks to increase their capacity. And so far, what we've seen within this pilot ran by Dr. Lumpkin and his team is that the approach has already directed about $12 million in FNS and SNAP benefits to more than 8,000 households across our state. So we really feel like that we're making an impact there, and that we are trying to really focus on something that we know is a problem, that we know is an issue. The other thing
one of the things that people don't understand, when we talk in healthcare in phrases, food insecurity, we've got tens of millions of people
absolutely
who cannot afford nutritious food for their families. We're talking about children, we're talking about elderly folks aging in place, and a big chunk of the tens of millions of people who qualify for food stamps or what's called SNAP currently are working. They actually are working
absolutely
part-time or full-time, and the bureaucracy, the challenges for someone who's poor or from a different cultural communities to actually just get enrolled. I happen to be on the board for the Alliance for Hunger. Just the number of people who want to but can't, that's a very different role for a health plan. But if you're hungry, you're 3 or 4 times as likely to hit the hospital if you were diabetic. I mean, like, you go down the issues of folks with chronic conditions, and then you add hunger, and the whole thing explodes. And we're just talking about getting people. I mean, that's a major step forward.
Absolutely, John. And look, North Carolina ranks among the highest in all of our states in the country for food production, but yet we also rank the highest for food insecurity.
That's insane.
That's a non-starter, right? And so I think some of this is also about stepping back and saying, where do we as payers have an opportunity to help build infrastructure and capacity within our community organizations? And then where do we have an opportunity, whether it is funding, whether it is influencing on the legislative and policy levels, and gosh darn it, where do we just have an obligation to just do, right? Where do we have an obligation to just step in and help do better and do more?
And people trust you. I mean,
absolutely.
Because the Blues brand is still the only brand in healthcare insurance where you can appreciably charge more or see more trust than any of the other insurers. I mean, that is the last bastion of a little bit of trust for health insurance.
Yeah,
that's
don't blow it.
absolutely right.
So maybe last question. What do you see as the role of the home for healthcare? I mean, historically, healthcare has been very much focused on the hospital, maybe the physician's office. Certainly during the pandemic, we've seen more of an overall emphasis on the home. How are you seeing it from your side?
Yeah, good question, David. So, beyond affordability, I would say that access is one of the most significant challenges that the healthcare industry faces, especially for those in rural or remote areas who face transportation barriers or challenges in getting to a provider's office for in-person care. At Blue Cross North Carolina, we've invested in programs and technologies that really help bring healthcare to home. So a couple of examples is we have a collaboration with Landmark Health, and they deliver in-home primary care for some of our most chronically ill Blue Medicare members. We have a Mom's Meals program, which provides meals to members who've been hospitalized, shipped right to their doorstep. And then we also have a Drivers of Health pilot that provides eligible members at risk of social isolation with on-demand companionship and assistance with everyday tasks, including transportation to doctor's appointments and grocery delivery. The key point is really this. The old way of thinking held that the doctor's office was the place that we went to go get healthy, right? A whole person approach to care and maintaining good health happens everywhere. It's in our homes, it's where we work, it's in our communities, it's in our mental health and providers' offices, it's in virtual spaces, not just the doctor's office. And so in order to fulfill our purpose as an organization, we must focus on healthcare beyond the doctor's office, and we must focus our efforts on where customers and communities live, work, learn, and play. At the end of the day, we must focus on health, and health happens majority in the home.
Good. Well, that's it for yet another edition of CareTalk. We're here at Health 2021, joined today by Alicia Stokes, VP Strategy, Planning and Performance for Government Markets at Blue Cross Blue Shield of North Carolina. I have learned a lot today. I have enjoyed it. I'm sure the same will be for our listeners as well. David Williams, Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. Thanks for listening. Please subscribe, and thank you, Alicia.
Thank you. It's been fun.